Okay, let's unpack this. We have a serious high-velocity stack of sources today. We're pulling excerpts from the highly respected Step Up to USMLE Step 2 CK textbook. This isn't just, abstract theory. This is core content. It's designed to be this rapid access guide to everything you need in acute clinical settings.
Exactly. I mean, these materials are famous in medical education for a reason. They just strip away all the extra complexity. They focus almost ruthlessly on what's necessary for board exams and, maybe more importantly, what's necessary to genuinely improve patient outcomes. It's all about those short, precise facts that guide your immediate actions.
Right. So our goal for you today is really to mirror that mission, to just cut through the noise. We're going to distill the most critical, high-yield clinical knowledge across a bunch of systems: cardio, GI, heme, trauma, endocrine emergencies. We're focusing hard on the differentiators, the specific findings you look for on an H&P or in the labs, and of course, those immediate life-saving management steps that are, well, they're always tested and they're absolutely crucial on the floor.
Mm-hmm. You should think of this deep dive as a necessary shortcut. When you're managing an unstable patient, you don't really have time to look up complex pathophysiology. You need that precise knowledge available instantly.
Let's jump straight into cardiovascular crises because rapid management here is just paramount. We have to start with a really foundational distinction. How do we clinically separate hypertensive urgency from a hypertensive emergency? Because that one line in the sand dictates the entire treatment plan.
It really does. The critical line, as the text defines it, is the presence or absence of acute end organ damage. So hypertensive urgency is defined by a significantly elevated blood pressure. We're talking 180 over 120 or higher in a non-pregnant patient, but, and this is the key, the patient is asymptomatic. There's no evidence of acute injury to the brain, the heart, or the kidneys.
So the body is somehow tolerating that insane pressure, even if we hate seeing those numbers on the monitor?
Precisely. If you find a 180 over 120 with zero symptoms, it's urgency. In contrast, a hypertensive emergency, which is sometimes called malignant hypertension, has that same extreme BP, but now you see acute damage. The source highlights key examples like progressive renal failure, acute pulmonary edema, aortic dissection, hypertensive encephalopathy, or papilledema on the fundoscopic exam.
And that single distinction, asymptomatic versus symptomatic, means the difference between, say, oral meds for gradual reduction and immediate aggressive 5E intervention. What's the goal with the IV meds?
In an emergency, the primary goal is to lower the mean arterial pressure quickly, but you have to be cautious, usually by about 20 to 25% in the first hour using IV agents. The source lists drugs like IV nitroprusside, nitroglycerin, labetalol, nicardipine. The choice really depends on what kind of end organ damage you're trying to protect. Labetalol, for instance, is a really common choice unless the patient has, say, acute heart failure.
Okay, let's transition to rhythm essentials. Can we quickly cover the ECG presentation of heart blocks, starting with first degree?
Sure. First-degree block is often benign, frequently just caused by high vagal tone. You're looking for that prolonged conduction time, so an ECG is showing a PR interval greater than 0.2 seconds. It's usually just managed conservatively. Now, if we jump to the total opposite extreme, third degree, or a complete heart block, that's a true emergency.
That's where the atria and the ventricles are just. They're completely divorced from one another, electrically speaking.
Yes. The ECG signature is really striking. You see P waves just marching along, totally independent of the QRS complexes. There is absolutely no relationship between the two. Clinically, these patients are often severely compromised. They're presenting with syncope, profound dizziness, hypotension. The treatment is definitive. You have to insert a ventricular pacemaker. You've got to bypass that failing conduction system.
Okay, let's discuss PSVT, paroxysmal supraventricular tachycardia. This often hits young, otherwise healthy patients, right? It's characterized by that sudden onset and resolution of a rapid heart rate.
Yeah, PSVT is usually caused by an abnormal reentry pathway. The heart rate is fast, typically 150 to 250 beats per minute. On the ECG, because the rhythm is so fast, the P waves are, well, they're often difficult to see, or they get buried inside the T waves. The QRS complex itself stays normal because the conduction below the AV node is usually intact.
And when you see this acutely, in a stable patient, what's the hierarchy of management steps?
You always start non-pharmacologically. You try to interrupt that reentry loop with increased vagal tonso, carotid massage, or the Valsalva maneuver. If the vagal maneuvers fail, the next step is IV adenosine. Adenosine effectively just slams the brakes on the AV node, providing this temporary chemical block that often resets the rhythm. But if the patient is hemodynamically unstable, they're hypotensive, have chest pain from ischemia, you skip the drugs and you move immediately to synchronized cardioversion.
Before we move on, we have to touch on one of the most dangerous rhythms. Torsades point. It's ventricular tachycardia, but with a terrifying twist.
Yeah. Torsades literally means twisting of the points. It's a really unstable form of VTASH, defined by that classic sine wave morphology. The QRS complex amplitude appears to oscillate around the baseline. It usually occurs when you have a prolonged QT interval, and it's highly unstable. It carries a poor prognosis because it often degenerates into fatal ventricular fibrillation.
And the high-yield treatment distinction here compared to, say, standard VTACH protocols.
Magnesium. The source stresses that magnesium is absolutely critical in its management, and it doesn't matter what their serum magnesium level is. It's because of its role in membrane stabilization. It is the immediate go-to therapy.
Okay, transitioning now to the abdomen and blood. Section 2 is packed with some really relevant distinctions in GI and hematology. Let's start with infectious gastroenteritis and a complication that can turn routine food poisoning deadly.
Most bacterial GI infections trace back to contaminated food. The critical alert in this section involves Escherichia coli O157IH7. This is the strain that produces Shiga toxin, and while it often presents with bloody diarrhea, the life-threatening complication is hemolytic uremic syndrome, or HUS.
Right, HUS. And what's a classic diagnostic triad for HUS that clinicians have to recognize?
HUS is characterized by three key findings. Thrombocytopenia, so low platelets, microangiopathic hemolytic anemia, which is destruction of red cells, and acute renal failure. That constellation of findings, especially in a child who recently had bloody diarrhea, demands immediate supportive care.
Moving on to peptic ulcer disease. This is a classic example of using the patient's history to localize the pathology. How do we use the timing of pain relative to meals to distinguish a gastric from a duodenal ulcer?
It's surprisingly reliable. If the patient has a gastric ulcer, often caused by H. pylori, they'll report abdominal burning pain that happens relatively soon after eating. Food actually makes the pain worse because it stimulates acid production.
Whereas the duodenal ulcer pain is delayed.
Correct. Duodenal ulcer symptoms typically show up 2 to 4 hours after eating when the stomach has emptied and that buffering effect of the food is gone. The patient might even say the pain wakes them up at night. And if you suspect H. pylori, the diagnosis is confirmed with a positive urea breath test or an antral biopsy.
Now for a surgical pearl, contrasting diverticulitis with appendicitis.
Right. Diverticulitis typically presents in older patients, often with a history of chronic constipation. The classic presentation is fever, leukocytosis, abdominal distension, and usually left lower quadrant LOQ tenderness.
But the clinical instruction for appendicitis, which usually presents in the right lower quadrant, is much more aggressive in that initial decision.
That is the high-yield instruction here. If you have a high clinical suspicion of appendicitis, classic symptoms like periumbilical pain radiating to the RLQ, anorexia, vomiting, the text says the crucial next step is to bypass delaying radiologic exams and just proceed directly to surgery. In those high-acuity cases, the risk of a delay from imaging outweighs the benefit.
Let's shift to hematology and the megaloblastic anemias. These macrocytic anemias often present similarly with fatigue, but the underlying deficiency and the specific blood smear findings are key, starting with folate.
Folate deficiency is highlighted as the most common cause of megaloblastic anemia. On the blood smear, you see the macrocytic red blood cells, but the absolute anchor finding that should make you think folate, or B12, is the presence of hypersegmented neutrophils. These are neutrophils with 6 or more nuclear lobes.
And vitamin B12 deficiency shares those blood findings, but what separates the clinical presentation?
B12 deficiency, which can be from pernicious anemia, that autoimmune lack of intrinsic factor, it causes fatigue and weakness, but it uniquely affects the nervous system. So the H&P will often include symptoms like memory loss, cognitive changes, or a peripheral neuropathy, which folate deficiency does not cause.
Finally, let's look at a microcytic differential that isn't just standard iron deficiency, lead poisoning. This causes a sideroblastic anemia. What's the distinctive smear finding there?
Instead of hypochromia, the distinctive finding is basophilic stippling. These are clumps of retained ribosomal material you can see in the red blood cells. Treatment involves, obviously, eliminating the source of lead and using chelation therapy, often with EDTA or DMSA.
One last rapid-fire heme fact. Sickle cell trait. Why is being a heterozygous carrier actually an advantage in some parts of the world?
Well, carriers are typically asymptomatic, but the presence of the trait gives them an improved resistance to malaria. It's a classic example of heterozygous advantage. And you have to remember, the presentation of sickle cell disease is delayed in infants until after 6 months of age because of the protective effect of high levels of fetal hemoglobin.
We move now into our third section, trauma, critical care, and endocrine emergencies. In trauma management, we all learn the ABCs, but the sources really emphasize the structure of the initial assessment. It's not just a checklist, it's a strict sequence.
It has to be rigidly sequential. Airway, breathing, and circulation, and the rule is absolute. You do not proceed to the next step of the secondary survey or exam until the current segment of the ABCs has been fully addressed and stabilized. For example, if you establish an airway but the patient stops breathing, you immediately return to B. You never move on to C.
And what's the critical default assumption about the spine in an unconscious patient?
The C-spine rule. The spine is considered unstable in any unconscious trauma patient. You maintain full cervical immobilization and restrict all movement until neurologic injury has been definitively ruled out.
Let's tackle burn management, starting with classification based on depth.
Okay. The classification runs from first degree, which is epidermis only, up to fourth degree. Second degree involves the partial thickness dermis that's characterized by painful blisters. Third degree is full thickness. It's often painless because the nerve endings are destroyed and the tissue looks charred or leathery. Fourth degree involves underlying muscle or bone, often seen in really severe electrical burns.
When a patient presents with facial burns, what's the immediate life-threatening concern that just overrides everything else?
Airway edema. Respiratory compromise. Any burn to the face, especially if it includes singed facial hairs or soot around the nose or mouth, is high suspicion for an inhalation injury. This means you need a rapid, proactive assessment and often immediate intubation before the swelling makes it impossible.
And once the airway is secure, the next huge step in managing significant burns, second degree or higher, is massive fluid resuscitation. We rely on the Parkland formula for that.
We do. The Parkland formula determines the IV fluid volume. 4 ml times kilograms of body mass times the % body surface area burned. But the clinical pearl that saves lives, and is often missed in the chaos, is how you deliver that volume. Half of the total calculated volume must be given during the initial 8 hours after the burn.
Okay, moving to another critical, time-sensitive emergency, tension pneumothorax. You mentioned it's a ball valve condition. Can you explain that physiology and why it's so dangerous?
In attention PTX, air enters the pleural space during inspiration, but the defect, it sort of seals during expiration, so it traps air and continuously builds pressure. That pressure doesn't just collapse the lung, it shifts the heart and the great vessels, the whole mediastinum, to the opposite side. This compression drastically reduces venous return to the heart, which leads very rapidly to shock and cardiac arrest.
So because of that, the clinical decision for a suspected tension PTX is aggressive, and diagnostic imaging is seen as a time-wasting hazard.
Absolutely. The clinical signs: hypotension, decreased breath sounds on one side, tracheal deviation, though that's a late signer enough. You do not wait for a chest x-ray. The crucial next step is immediate needle decompression, a large bore needle into the second intercostal space at the midclavicular line. That converts the tension pneumo into a simple pneumo and restores circulatory stability.
Our final high-yield differential covers diabetic acute complications, DKA versus HHS. Both are high glucose emergencies, but they're managed very differently.
The key is insulin. Diabetic ketoacidosis, DKA, happens most frequently in type I diabetics because they have virtually no insulin. This leads to massive lipolysis and then ketogenesis. Labs show high glucose, usually 250 to 800, a high anion gap metabolic acidosis, and high ketones in the serum and urine. Clinically, they often have those Kussmaul respirations and the classic fruity odor on their breath.
And hyperosmolar hyperglycemic state, or HHS, involves type 2 diabetics. Why do they avoid the ketogenesis part?
They retain just enough basal insulin production to inhibit that significant lipolysis and prevent the development of ketones. So HHS patients have extremely high glucose levels, often 600 or more, frequently over 1,000. But crucially, their labs show no significant acidosis. They have a profoundly high serum osmolality, though, leading to severe dehydration and mental status changes.
So the three immediate differentiators are blood glucose level, presence or absence of acidosis, and the patient's history of DM type. Wow. We have synthesized some of the most critical decision points in acute care medicine today. moving from cardiac rhythm management through rapid surgical decisions all the way to stabilizing metabolic crises. The sheer value of this material is in its precision.
They're the facts that have to be instantly recallable. Mastering these short, precise pieces of knowledge is what allows you to move with confidence and improve patient care during those high-acuity, time-sensitive situations.
Let's leave you with a quick review exercise to lock in those metabolic differentiators we just talked about.
Okay. A 70-year-old patient with a history of type 2 diabetes presents to the ED with severe dehydration and altered mental status. Their blood glucose is 1100. Lab work reveals a normal pH and no ketones in the urine. Based on our discussion, what is the specific complication the patient is experiencing, and what is the primary physiological reason DK is considered less likely in this scenario?
And finally, a provocative thought that often catches clinicians out, especially concerning the type 2 diabetic population we just discussed. Reflect on the concept of the silent MI. Diabetic patients are at a significantly increased risk of silent myocardial infarction, experiencing little or no chest pain due to autonomic neuropathy and impaired pain sensation. It's a crucial reminder that textbook disease presentations are often masked in specific populations, and cardiac complications remain the single greatest cause of death in diabetic patients, whether they feel it or not.